there were definitely situations when you had difficulties in sleeping, that your appetite might have been off, that you were irritable. These are all symptoms and signs of stress that we were all facing. So our colleagues definitely who were right in the front line definitely also had the same, if not more, levels of distress. So I think, we have to take on board that the COVID-19 did not spare anybody, whether you're a healthcare provider or not, whether you're a psychiatrist or not. We often say that people in mental health have greater resilience because of training. But again, this particular pandemic, I think, spared no one. We were equally as affected as everyone else. Probably the only difference is that we had a little bit more arsenal in actually managing our stress compared to other people. But everybody was actually not spared during this particular pandemic.
Yes, exactly true, Prof. Amer. And also, you have mentioned something very important just now on how COVID has actually changed a lot of things. In fact, in a systematic review, I was just reading the other day, July 2020, where they reviewed 154 articles. They found many causes of stress actually during the COVID-19, and some of it which you have correctly mentioned just now. But also, they have found that COVID-19 itself, just dealing with COVID-19 itself, is an independent stress factor by itself now. And you're absolutely spot on by saying that we are dealing with this new pandemic, and it is something which is so different than what we have normally experienced locally. But I think one of the more important things is, I think if you talk to most of any general practitioner, physicians, they normally tell you that the common mental health issues that they see among their colleagues on themselves are depression, anxiety, and stress. And they may be the frontliners who actually detect them, who refer to professionals like Dato and yourself. But sometimes I think that medical health professionals are also at fault for not looking after themselves, and they may be having symptoms, and at the same time, they don't actually seek help. So can I get the panel, the panel of both Dato and Amer to probably, Prof. Amer, to just share what are the signs that we have to look for as mental health professional, because we may not be seeing another doctor, which we should, by the way, but because we are not, how do we recognize these signs and symptoms of mental health, especially for depression, anxiety, and stress? Maybe we can start with Dato.
Well, I mean, mental health professionals probably know all this, like, they have the textbook knowledge of all what are the signs and symptoms of depression and anxiety. But as you rightly said, probably in this particular case, what would be lacking is accepting the fact that as mental health professionals, we too are human and we too are susceptible. So it's going to be a very tricky situation here. Like, we know what happens when stress can be so overwhelming, and as if it's going to result in a depressive disorder or an anxiety disorder. And obviously we also know the fact that we have to have a persistent sadness for a particular period of time for about 2 weeks or so. We might end up being very irritable in the workplace rather than showing a sort of sadness, but it will be more of irritability in some cases. And we are just, it is all characterized by hopelessness and also very pessimistic thoughts and actions. And we feel fatigued or simply not motivated to do things, and certainly to also treat our clients as well. And we might also, weight changes. I wouldn't say necessarily weight loss, but also, weight gains, depending on whether we have increased appetite or lowered appetite. Sometimes even medical professionals and certainly psychiatrists are not spared in this case, where we could also some thoughts of death wishes, passive death wishes, or even active suicidal thought. Professionals themselves, though, are very well of digestive problems and things like that. We too have faced that. Unfortunately, the main problem here is of denial. And I think, you know, and that's where in some situations, in some countries, in some systems, you have a very good, you know, buddies or a peer review kind of a mechanism to ensure that mental health professionals themselves do not succumb to you know, decompensated psychological situations. So I think that's the greatest challenge here. And you know, this might be a little bit neat. I mean, Prof. Amer might be able to add a little bit into this, but I think the mechanism to have a watch over peers is somewhat needs to be fine-tuned a little bit in Malaysia. But you know, we could emulate other countries in this respect to ensure that not only the mental health of our colleagues, but also as a result of their decompensated mental health status, they, you know, they're not shortchanging the clients in any way.
Yes, I completely agree, Dato. Sometimes, you know, we need to have colleagues who actually look out. Like I have seen particularly many times that a colleague looks in a certain way, or you know, sometimes you find that suddenly they have some stigmata of dyslipidemia, and I go and say, hey, when was the last time you checked your cholesterol? You know, something of that matter. I think you're absolutely spot on that perhaps the best people to actually look at and diagnose or even look out is our own colleagues. And I can see Prof. Amer smiling. He has a lot to say about it. Prof, can we get your thoughts about it, Prof?
Well, I think first of all, as I mentioned, we often judge ourselves higher than other people, and also when it comes to situations like this, we often think that we are stronger than other people. But as I mentioned before, in terms of mental health care and also physical health care, we all know where we all stand. You know, how many times have all of us given advice to patients to exercise, yet when was the last time that you actually did an exercise yourself? So same thing, you know, you might ask individuals to manage their mental health, yet number one, you might not do it yourself. Number two, you might not know how to do it. You know, I've been going on recently to share with people situations to the public where if someone fell down and collapsed, what would you do? And probably most people would say they know what to do. But if someone reached out for help, a mental health cry for help, would you be able to provide the same kind of help that you would if somebody collapsed on the middle of the street? So it's going to be the same concept in terms of mental health among us during this COVID period. Because as Dato rightly mentioned, we were experiencing symptoms and signs that we perhaps did not even recognize. For example, the time when you felt that you didn't want to go to work because you just felt you didn't want to go out because you're just so tired, and you're not tired physically, you've rested, but you're just tired mentally. That could be a sign that you're struggling with a mental health situation. The time when you were starting to refuse to actually front up on the front line because you're afraid to be contracting the disease, even though you probably know most about COVID-19 compared to the other people. That itself could be a mental health symptom and sign. What about that time when you were extremely snappy with your colleagues and friends? You know, irritable when you're generally quite a calm, nice guy. Those again were symptoms. So if you were not able to recognize those symptoms yourself, therefore you probably were struggling with some level of mental distress during that period of time, which probably went unrecognized. And if it persisted for the whole period of the early stages, I'm pretty sure that you will be a different person now than you were prior, because you would have had to absorb the great deal of distress and stress during that whole period of time. So these were some of the, you know, one of the reasons why colleagues were not coming forward is because they were not able to recognize. And this is where, you know, the positive thing about us is that most of us, at least, you know, my colleague in the Ministry of Health under the NCD group, which Dr. Norashikin led for the mental health level, had decided that they built this mental health psychosocial support system across the Ministry of Health, in recognition that colleagues were also struggling during that period of time. Now, fair to say that it was not as immediate as when we responded to COVID-19, but it was not too far after that. And of course, colleagues in my university and other universities also had the same level of mental health psychosocial support system put in place within about a month or at least 6 weeks after that particular period of lockdown. So we recognize that people who are on the front line day in, day out, doing all the screening, being exposed to risk, seeing their friends and other people being sick, were definitely going to be affected with some level of mental health strain. So there was really put in place some system in order to assist them, which continues until today. Now, our limitation is number one, are we still acknowledging that mental health is going to be a pandemic that is literally not talked about? I mean, most of you are watching the news. We don't hear of budget being put in for mental health support. Secondly, is that do you know about your mental health psychosocial support system within your state or your hospital for you to get help if you need it?
Yes, I quite agree with you, Prof. Amer. In fact, in the UK, they actually have a ministry for mental health, and I think Dr. Rosina Alin Khan is currently the shadow minister, quite a vocal lady. And she has also mentioned that in May 2020, that the suicide among healthcare workforce was rising, especially among the NHS, and the needs for mental health crisis centers, more personnel for it. And personally, I have seen doctors who have, like what you said, started breaking down, not wanting to go to work, especially when we just started the pandemic, because everybody knew so little about it. And I wanted to get some opinion from Dato Andrew. Maybe you can share. I saw you putting up a slide. Maybe you just want to share with us, sir?
Yes, yes. Thank you very much. And you know, there are 2 points really, and one interesting point you raised just now about leadership in mental health, and I'd like to comment on that a little bit. But before that, just adding on to what Prof. Amer said just now, that, you know, the medical profession is always very heroic, and because we have been, you know, used to doing to bad days in the work that we do, and that's why we signed up to be a doctor or a nurse or a paramedic, or, you know, in a member of the caring profession, and we look at it as a vocation, at least in most cases. And you know, I just like to share this little bit of information here. When I was trying to promote debriefing in a particular country recently, and this is through the online like webinar like this, and when I suggested that you know, it must be made compulsory at least twice a day before the shift starts, whether the frontline workers go outside on field work or remain in the hospital setting, particularly in the ICU setting. And I said before the shift and after the shift, there must be a debriefing for the reason that, you know, I mean, it also in certain situations where people are susceptible to a lot of rumors about the patients, about what, you know, how dangerous it is for them to face the patient and things like that. So it's very useful. And I kept emphasizing on the need for this, but I got an impression that most of them were not interested in this. A number of them actually felt that, you know, this is not meant for them. One guy actually stood up and said, you know, I have seen Ebola in my country before, and, you know, if the COVID comes to me this time, I'll go to the COVID with my fist like that and just give a knock, and that's it, COVID will disappear. So that's a kind of heroic thing that the medical, you know. And then sometimes we understand that this is important, but they don't want to burden anyone. They don't want to burden the whole system. And one person came up with this brilliant remark saying that it takes 1 full hour to take off my PPEs, and I can't wait to go back home. So what is all this, another hour sitting down and debriefing? I don't want that. So, and in many societies, the very fact that they're sitting down and having a psychological debriefing exercise, particularly for team leaders, you know, so these are things that I'm sure also in some ways has got some, you know, similarity to the situation in Malaysia. And the other issue that you raised just now about leadership in mental health, I mean, this is something that I'm quite passionate about this, having been, we're familiar with many other countries in the world. We've been in Australia, many states, two states now actually have ministers for mental health. And in Europe as well, you see this in Scotland, in Wales, you have ministers for junior ministers for mental health, and of course the Scandinavian countries. And in many other places, even if they don't have a minister or junior minister for mental health, they at least have some sort of a commissioner for mental health or an ombudsman body for mental health. Clearly, that is the way that we must head in our country. And even if you cannot have political leadership or in the executive, but I think the legislation in some ways must reflect this. Only then we can, constructively debate on how we move forward in mental health in this country. And just now, as Prof. Amer mentioned, just now we are not even sure of the budgetary allocation for mental health support in the new budget that's going to be presented. So these are things that has to be looked into. And if we want to show the world that we have, we have arrived, I think mental health leadership is also very important. And thank you so much for bringing that matter up.
Great, thank you, Dato, so much. Actually, there was another paper which I was reading. Some of the causative factors for these mental health issues, especially in our healthcare professionals, we have some of the factors working in high-risk departments, like I think in the accident and emergency department, working in the infectious disease department, exactly like how the panelists have put it, the diagnosis of a family member, inadequate hand hygiene. We have heard of hospitals, not only in Malaysia, let's talk about around the world, where they didn't have enough hand hygiene material. They were reusing their PPEs, using UV rays to, disinfect their PPEs. Improper PPE use, close contact more than 12 times a day. With patients, long daily contact hours, as we have heard many of them cry, under unprotected exposure, poor sleep and rest, as what Prof. Amer has mentioned, and sometimes that guilt and feeling of not having done enough, like staff not getting enough of food and family time, exposure to family members, like what Dato has mentioned, that you go back and not only the family thing, is he bringing back or is she bringing back the COVID at home? We ourselves may think, am I bringing it back at home to my family? And the long hours, especially in Sabah, which we have found many of them, and in fact in the country where we have heard of Kajang, where they were not being paid or being underpaid of their COVID-19 allowances, all of this which actually affects some form of another. So maybe Prof. Amer, you can just share with what are the other factors which may particularly affect mental health in our healthcare workers during this COVID-19 pandemic?
Well, I mean, thank you. The most obvious one is going to be a history of mental health. I mean, again, just because you're a medical practitioner doesn't mean that all of us are immune from mental health situations. So we don't have that kind of support at times for colleagues. So those who are struggling with a mental health issue, which are either diagnosed or undiagnosed but not informed, definitely will be at higher risk. Again, we are not immune from the same psychosocial situations. If you're having trouble at home with your family, particularly, you're definitely going to be at risk. If you're going through some financial difficulties, just like our public, you're going to be at risk. Again, financial literacy in Malaysia is only about 30%. We're not, most of us did not have a first degree in accounting. I'm pretty sure that some of us don't know how to manage our money very well. So this increases the risk of developing some problems with mental health. Poor social support in terms of the workplace. Not everybody is understanding. Remember, all of us were expected to work long hours. At that point of time, some of us, if your mom and dad, i.e. you or your spouse is a medical doctor, who's going to take care of your children? There were some very difficult, employers out there or bosses out there who were not as understanding to the fact that mom and dad are not available, and therefore, expecting both of them to work at the same time. So again, this caused a lot of stressor in terms of who's going to manage their children, particularly when some of them are not actually in the same state as their family members. Remember, during the MCO, everything was closed. You can't send your kids to a nursery because there's no nursery. And we've heard of cases where if it's a doctor's child, nobody wants to take care of them because they were so worried about contracting COVID, the stigma at that point of time. So these increase the risk of mental health, symptoms and signs for some individuals that often is forgotten. Yes, I agree with you, Arvinder. Situations like poor working hours, the difficulties in getting the right material. I mean, in the first week, again, we were caught off guard with the situation. There were lots of complaints of a lack of equipment that increased definitely the stress level for those who were expected to be serving. But most of our risk factors are going to be the same as the population out there as well.
Yeah.
Yes, absolutely true. And I think, Prof, when we talk about doctors having mental health issues, I think it would be appropriate to bring up at this point on how UK has a particular center for doctors, or even let's put it as healthcare professionals who are having any mental health disorders. And there's some amazing statistics which I've actually looked at, which I've read from their annual report. And they said that the proportion of doctors or healthcare workers with mental health disorders is actually higher than the general population at 19%. And 17 to 52 of them percent on studies done had showed that 31% of doctors in general had mental disorders. They have gone on to mention some departments which are higher risk, but what amazes me was 34% of trainee doctors actually suffered mental health issues. And most of them who have even 36% of consultants actually had depression and anxiety. Most of them from departments where they deal with a lot of dying patients, like especially oncology and palliative care. So it brings down to the point, as what you and Dato said, that when we're dealing with dying patients, and normally, even though in the casualty they do deal with dying patients, and even in the ICUs, I think most of the time is due to some chronic disease and not such an acute thing that can happen. At this point of juncture, that we are seeing a lot of them who are probably perfectly healthy or with undiagnosed conditions, they are coming in and straight away going under the ventilator and then sadly passing away. I think it is affecting quite a number of them. And even 16 to 36% actually talk about post-traumatic stress disorders, especially those people who are looking after COVID in Italy. And sadly, suicide is also not far from some of these doctors' thoughts. And 4% of them, of registrars, and 23% of junior doctors had actually once attempted suicide. And I think what are the other risk factors, personal individual risk factors, which perhaps doctors or healthcare workers should be looking out for? Maybe Dato, you maybe is that are you okay for that question, Dato?
Well, I mean, to be honest, I was a little bit. The statistics that you mentioned just now is actually quite. I mean, it's a little bit shocking, really. But I'm not entirely surprised. Simply because I think doctors. I mean, we have discussed this just now. Prof. Amer himself also mentioned this. I mean, we think that this is what we do as members of this profession, and we tend to be very heroic about it. But I think it's important that, the alarming statistics you mentioned just now is also probably a reflection of the burnout that you find in mental health workers. There are other reports as well coming from other parts of the world that shows very high rates of burnout among mental health workers, and among non-doctors, among nurses, mental health nurses also, there is that vicarious trauma that seems to have taken in Australia, and we have also anxiety. But I think the real reason for this is, again, coming back to the fact that doctors particularly, and of course all members of the health profession, particularly mental health profession, really don't know the limits, our own limitations. We just don't understand what that means. And a part of the reason for this is a reflection on the kind of training that we get. We've always been exposed to this. From the time you entered the profession, you're told that other people's needs to be prioritized compared to your needs, and you are basically a hero. That's why you joined this profession. The profession also needs to be blamed for this because, traditionally our superiors, our consultants have also in some way bullied us into thinking that this is how, this is what makes a doctor. And I remember clearly many times when I was a houseman, I was told that, that it's better that I just jumped off the balcony or continued rather than continuing to be a doctor, and then you get humiliated in front of the clients, of the patients. One consultant actually told me that I'll probably better be selling dosa under the bridge rather than wanting to be a doctor. So we are fortified by this sort of after a particular period of time, and this is very true among mental health professionals also, because then we think that we are immune to any form of psychological decompensation, and we are not supposed to decompensate in any way. And I think that is the real problem with doctors, and the fact that there's a lot of scrutiny in the work that doctors do in many societies, including the United Kingdom, that has resulted in this, the statistics that you have quoted before. But ultimately, it all boils down to the fact that whether we are doctors or nuclear scientists, we are not God. We must understand our limitations. The moment we feel that we can't handle a particular situation, then speak to our superior and see how we can reorganize our, because there's nobody to supervise us, generally speaking. Particularly when you reach a certain level of seniority, then you think that you should not be supervised by anyone.
Yes, I agree. In fact, Dato and Prof, Prof Amer, before I go to you, do you think that it is actually becoming an occupational medicine related issue which we should be looking at? Because I have been an advocate since I think about 2 years ago, where I actually felt that mental health assessment should be part of occupational health screening, like how we have our SOCSO screening every year, the PERCESO screening. I always feel that it is quite simple to actually just give them a basic screening, talking about maybe the DAS scale, just to quickly fill up, just for a quick screening. And if we look at the Society of Occupational Medicine, they have talked a lot about depression and anxiety, especially in healthcare professionals. They have looked at suicide among GPs, psychiatrists, and trainees have increased. Burnout, I think something which we have not probably discussed yet, leading to all the other issues, especially among GPs, on emotional exhaustion. Absenteeism, I think we have discovered quite a bit of that, causing stress, not only to the person who is absent, but also to the team who has to cover the doctor, which is unavailable. Some among the factors of which can cause depression, anxiety, and stress, especially during the COVID time, is because of absenteeism. A lot of them end up getting bullied, like what you have correctly mentioned, Dato, by the superiors, by the colleagues, by even patients. Sometimes there's conflict, and even with personal conflict and conflict between life, and some implications as patients' demands become higher. I've also read a few places on individual factors, but maybe we will talk about that later. Prof. Amer, what do you think of it being an occupational health issue?
Well, I think definitely it needs to be addressed. We are, for this year's theme, if you did not know, we're looking at Let's Stop Minda Sihat, mental health access for all, together preventing suicide. And if you looked at the press statement that was given by the Ministry for World Mental Health Day, we are focusing mainly on adult workers, because as we know that currently during this pandemic, people are losing their jobs, people are concerned their jobs might be lost, people who are seeing other people losing their jobs are also affected. And if you have children out there who are going to join the workforce, you're not even sure whether there's a job available for them. So we're focusing on mental health at the workplace. And similarly, those who are in employment at the moment are at greater numbers of stress because, number one, their workforce has shrunk as a result of the economic situation. They're asked to take bigger roles. Secondly, is that they're working, we were discussing just before this webinar started, working at home or working from home. And it's not something in our culture to be working from home. So therefore, there's a period of adjustment that is required, which some people are not allowed to take. They're just meant to straight away work in like everything's okay, but things are not okay. Things are different. So definitely focusing on mental health at the workplace as being part of the occupational safety and health will definitely help. It will help in a few ways. Number one, it will help in promoting awareness on mental health as part of health, which I think, again, we tend to forget. If you need a reminder, WHO defines health as not only physical health, but social well-being and also mental health in the absence of any disease. Therefore, mental health is part of health. The second one is that having an agenda for mental health at the workplace also improves the working condition. If you're again not familiar, the Human Resource Ministry has actually produced guidelines for companies in order to promote good mental health within their particular organizations, whether it's an SME or a multinational. However, many of us probably are not aware of this, and we're not alone. The companies themselves are not aware of this. Therefore, the cases of bullying that we often see, the cases of poor availability of resources, the cases of discrimination happens within workplaces, not only within our system, but also in other systems out there because they're not probably adhering or knowing about these guidelines. So once you have this agenda on the occupational safety and health radar, and some of you here who probably are involved with SIRIM and other audits, then it becomes an issue that you need to pay attention to. And once that is put in place, the issue that was discussed by Arvinder should be addressed. Now, I wanted to also focus on something Arvinder mentioned about absenteeism. Now, the Harvard Business Review talked about the biggest cost at the moment of loss of productivity is not only absenteeism, which is often seen, but it's actually presenteeism. In Malay, we call it buat-buat busy. Nampak ada dekat situ, tapi haram tak buat apa-apa kerja. So, and some of these people are not because they are lazy, it's because they are struggling with some level of mental health care. I'll give you another example. One of my roles in the University of Malaya is also the director of Cares, which is the Center for Community Engagement and Sustainability. So I've got about 12 people under me. So it's not a big team, but it's a team nevertheless. And one of the things I realized is that if you're worried about COVID during that period of the MCO, even though we try our best to support you, i.e. you're worried about your children going to school or not going to school, you're worried if your husband or wife had lost their jobs, you're not going to be working productively. You're not going to be working productively at all. So I think what we did was that we actually had an internal program within our unit to support families that might be requiring some level of maybe financial help, financial literacy support. Sometimes it's not about the help, it's just making sure that they didn't blow all the moratorium that was given to them during that 6 months, so they knew how to budget. We linked them up with lecturers who could provide some level of teaching and learning so that at least the support staff particularly were a bit more aware about what's available for them. And just providing that little bit of support allowed them to feel a bit more comfortable, that their families are supported and therefore they're able to work a bit better. Now imagine in a situation where we didn't focus about mental health and all of this was not put in place, we'd be expecting them to be working at home and working from home at the same level as if they did not have any dependencies and any issues at home, which is of course is impossible. And this is what sadly is happening with our profession, as Dato mentioned just now, where we're expected to be working as if we don't have families, as if we don't also have concerns about our ailing mother and father, about our spouse who might have just lost a job, about our children who are not going to school for the last 1 year. We really need to be a bit cognizant that everybody's affected by the COVID pandemic.
Yeah.
And again, if we put in, mental health in part of the workforce, I think some of these concerns would have been brought up earlier to prevent loss of productivity in terms of presentism and also absenteeism.
Yeah. Can I add something to that? I fully support what Prof. Amer was saying just now, and the fact that now recently, I think in our country we have woken up to some extent on the actual cost to the productivity and on the fact that this can the corporate sector is also now beginning to realize that there is a big link between productivity and mental health. Now, the fact that Prof. Amer mentioned about presentism, just coming to work and clocking in and going back, but then the fact is that they're not being productive because of their mental health issues. Now, while we know, when we have discussed before, ways and means to detect mental health deterioration in our colleague in terms of their demeanor, their productivity, their engagement, or even if they are abusing substance, whether they smell of alcohol when they come in the morning. Now, what happens to all this, and how do we deal with a situation in which a significant part of the workforce might be operating from home? I think this is also a great challenge now for managers to understand if their subordinate is having some sort of challenge from working from home. I mean, people have said something about, like how to detect it through the emails, whether they're responding to the emails on time or whether they're being very terse, very matter of fact in their emails. How do they sound over the phone and things like that? But I tell you, this is going to be a major challenge because as it where people are not very open about their mental health challenges in the workplace. Now you're going to have this cohort operating from home, and what's going to happen there, and how are they going to be monitored? What sort of support can be offered to them? I mean, these are things that are waiting to be flashpoints, really. Yeah, that's my take.
So, yeah, excellent discussion. I also read that there are a couple of risk factors which actually cause mental health disorders, especially in COVID-19 era among doctors. Some of it is perfectionism, indecisions. I think we saw quite a bit of that, especially when the start of COVID, when there was a big debate about remdesivir, hydrochloroquine. I think there's still some debate going on there. So indecisions, I think non-agreement between particular doctors and consultants, some high self-criticism which has been going on, low flexibility, highly disciplined, idealistic, and high degrees of empathy. Perhaps sometimes getting too involved, especially with patient care and empathy. I think some of them do actually feel, I think, especially when a patient passes on. I personally have experienced when a patient who you become so attached to is sitting in the ward for so long, and suddenly you come one morning and they're not there anymore because they have lost their life. If they've been discharged, you feel happy, that actually they've gone home to lead their normal life again. But then if you find out that they've passed on, it becomes a very a personal thing at times. And especially as what Dato said just now, that some of them come, in the morning smelling of alcohol. In fact, they've even seen that some disruptive behavior or even mental health issues causing substance abuse, or even vice versa. The substance abuse which is causing mental health are also among some of the things. Maybe we're not seeing it much in Malaysia, or maybe it's underreported, but perhaps we're seeing it much more in other countries as well. So Dato, can I get your opinion on that?
Well, sorry, I mean, is it the opinion on exactly what was it? On
perhaps substance abuse leading to mental health disorders, and mental health disorders leading to substance abuse during our COVID-19.
Yeah, absolutely. I mean, I think so. People are trying to, cope with all these difficulties at this time with using excessive use of substances as well. And of course, there is a link with, substance abuse and and psychiatric conditions as well. And part of that self-medicating would be to cope with the situation or their condition is to use alcohol extensively and excessively, as well as some other illicit substances as well. But the fact that the use of illicit, even recreational substances, for recreational purposes can also vice versa result in a long-term psychiatric condition as well. So, it works both ways. But the fact is that in this particular situation, when you have medical professionals, trying to cope with this while there's a great deal of expectation, in how in their role as care providers, or rather mental health or medical professionals, then it does become a little bit of a challenge for them. And we see this in many places, including Malaysia, where some of the professionals who are known to abuse substances would come from the medical profession. And simply because, as you have said, of the workload and the fact that we do not compromise on standards, and we are very unshakable in our doctrines on how to handle this case. I have an example where one particular doctor, came to one of the Pacific countries, not Nauru, in some other Pacific country, and he rubbished the use of hydroxychloroquine. And the local doctors have been always using it here. I mean, it's not published and all that, but people have been using it prophylactically as well. And so they were really upset with this doctor who came from a different background, different first world country, and rubbished this whole thing. And of course, that doctor was put on the next plane and sent back home. But the fact that when it comes to interventions in COVID, the therapeutic interventions, there are so many different opinions, and each person is steadfast in his own opinion. And never before, I don't think you will see that sort of a situation in any other profession, where in the medical profession, particularly in the mental health situation, I mean, Prof. Amer is well aware of this dictum in the university that we went to. We both went to the same university, where it was said that if you had 10 psychiatrists examining one patient, you will have 10 different diagnoses. So we are quite steadfast in what we feel, and that also has an impact on our work, particularly at this juncture. And that is why we are much more prone, I would say, to abusing substances and even having fatal consequences as far as abusing or illicit substances.
Prof. Amer?
Yeah, agreed. And I think the other thing that we have to take note is, for us in the medical profession, one of the reasons why there is an opportunity to abuse substances is because we have the availability to do so. And therefore, I think that's really important for us to play our role together in check and balance. I just wanted to just revisit again what Arvinder had mentioned just now in terms of suicide among medical physicians, particularly, and also in terms of the substance. I just wanted to put it across to you that these numbers are not that high, to begin with. But there's something that we need to not cherry coat, and it's something that we need to be aware of, because they have happened in other countries. It's not impossible for it not to happen here. It's just that these numbers are actually quite small, probably because one of the protective mechanisms for suicide is religiosity, and I think most of us at least have some form of that within whichever culture or religion that you have, which I think it's a good thing. It's a protective mechanism. But again, if we don't do something about the situation, and like I said, COVID-19 pandemic is definitely a pandemic, but the mental health consequences of COVID pandemic is also going to be a hidden or unrecognized pandemic, which we really need to address. Already, if you look at our colleagues and friends in Sabah, who are really battling the COVID over there, from what I've been told, really difficult not only in terms of the resources, but also in terms of the mental health need. And all the experience that we've had in the mental health psychosocial support systems that we've put in place during the early year needs to be re-emphasized, if it's not emphasized already, among our colleagues in Sabah. And again, for some of you here that might be from Sabah, please, again, be aware that the 15999 number is still on, that the team in the Ministry of Health is still working on the psychosocial support system. And if you don't have that support system, then please convey that message that you require it. No, we did a study in during this period of the first COVID. And even though there was very little people that externally voiced out that they needed help. But once the MHPSS system was put in place in the hospital, when we called them up for those who scored highly on stress, depression, or anxiety within the screening tools that were given, they really appreciated that extra support given by the hospital in terms of just taking care of them. Very simple, small amount of effort, low cost, and more importantly, it had the opportunity to prevent colleagues from actually having a mental illness, which is the ultimate thing that we want to avoid, or God forbid, going through some of the statistics that Arvinder had mentioned, abusing drugs because they're unable to cope, as Dato had mentioned just now, or taking their lives because they felt so unsupported and so overwhelmed with the situation because of that lack of support. So just a little bit of work can actually go a long way.
Yes, thanks, Prof. I think, sorry, Dato. Yes, Dato, please go ahead.
Just one line, just to emphasize, or rather, reiterate what Prof. Amer just now mentioned. I think there was a documentary as well, and a BBC publication referring to this mental health problems as a result of COVID as a crisis within a crisis. So that that was the heading of that publication, just to show that this is so much hidden within it that we tend to overlook the consequences of this mental health crisis. Thank you.
Yes. Thank you, Dato. So some of the things which we actually have to look as individual factors which actually can cause mental health issues among healthcare workers. In the COVID situation, without the COVID situation, we have looked some of the factors which I've identified, especially from meta-analysis. They say that being a lady or female actually has a higher risk for having mental issues, but I think that has been debunked lately because I think they are more open. They come out and they say it. A lot of males may be having the issue, but they like what Dato actually and Prof. Amer has said, that you think you're a superhero and you try to stay, and I think that is actually not very healthy. Mechanism of coping up with stress, grit and personality, who your bosses are, exactly like what both of you have brought up just now. Higher risk upon certain specialities, satisfaction at chosen specialities, and very interestingly enough, uncertainty about career options and pathways. Now we are seeing that lately, especially with our I think junior medical officers who are not given permanent jobs and always on how shall I say, a contract basis, and most of them are dealing with that and COVID at the same time. They go to work, not knowing that whether they will be again heading to work in the next couple of months. I think that's also another issue. But bringing all of that into perspective, our mental health support for our healthcare workers, where are we particularly on that level in Malaysia? Maybe I can get Prof and Dato to maybe just state a few things. Thank you.
Maybe Prof. Amer can start on that.
Well, I think just going back straight to the question that had mental health support for our healthcare providers, I think it's still in its infancy. There's still lots of discrimination within the system in terms of mental health care. I'll give you a simple example. Somebody has a heart attack. You're probably quite empathetic towards his, medical situation. Somebody tells you that he has depression and is unable to come to work. You wonder why he had depression to begin with. You didn't wonder why he had a heart attack. You didn't ask whether you shouting at him yesterday caused him to, increase his blood pressure and subsequently have this heart attack. But you want to ask all the questions, the 101 questions about, why that this person has a diagnosis of major depression. That itself is discrimination. You question the MC of somebody who has depression. You don't question the 6 weeks that you give because the fellow broke his leg, for example. They, of course, they might not be the same, but they are the same. They're both medical conditions, which we all recognize to be true.
Absolutely.
So definitely is going to be one reason why, why I say that the support is in its infancy. Secondly, again, as I mentioned just now, we thought about the patients. We always think about the patients, and I think that's a good thing. But we also need to think about how many hospitals out there has some level of employee assisted program within their system. How many hospitals out there actually allow you to take breaks because they know that you might be struggling with a mental health situation? If you didn't think about it at all, i.e. it's not in your system at all, even in your consciousness, then we know as a profession, as a group, that we are still quite early in the stage of understanding about mental health, and also in terms of adopting health, the whole total health as stipulated by the World Health Organization. Dato?
Dato, maybe you can just add to what Prof. Amer has said.
Well, actually, I think Prof. Amer has actually, mentioned that so succinctly here. And the thing is, even within our system, I do understand that the major issue here is, probably unwittingly having discriminatory practices, although we may not intend to do so, but we are influenced by our own cultural background and our own belief systems as well sometimes. But the fact is that we need to work towards having a mechanism ingrained within the system to prevent any sort of discriminatory practices. I think that is seen, that is the difference seen in some countries that ensures that the system itself cannot have an option of having any sort of discriminatory practices within the system. For example, in many countries, if at all an employee has got a mental health issue, then he or she cannot be discriminated against in an interview process for promotion, for example, unless it can be proven that that particular mental health issue of that employee has not been addressed properly, and it might have a bearing on the new job descriptions in the event that that particular employee is promoted. Now, we don't see that in our systems in Malaysia, and definitely not in our health systems when it comes to particular doctors having some sort of psychological decompensation. I've seen a number of them where even if they did not want to get out of the system itself forced them to leave the system and to make them feel that they're not good enough to be a medical professional. And there are some systems, some mechanisms, or some ways in which we can mitigate the difficulties faced by mental health professionals. For example, we can have a system in which we rotate staff from a high stress function to a low stress function. Frontline workers, we're talking about frontline workers now. So that sort of mechanism can be put in place. We can also, and ensuring that there are safety measures in this COVID-19 scenario, and encourage regular work breaks, or even ensure that flexible working hours are possible for those employees or those health professionals who have an infected family member. And of course, as Prof. Amer said just now, one clear indication of our apathy towards this is the fact that none of our hospitals have an EAP system or something like that to let the health workers know that there is a independent or non-judgmental psychological support service. And in this whole thing, of course, we should also pay special attention to our health professionals who may have some pre-existing mental health or neurological conditions. And often we judge these, people with pre-existing conditions rather harshly as well. So on the whole, I think, I like the way Prof. Amer has expressed this. When if you want to know where we are in this, all you have to do is to see what are the systems in place, or whether or not we even think about this. The fact that it's not in our consciousness itself is a reflection on the way things are now. But I do feel that the COVID has, in some ways, has had a silver lining as well. Because of this COVID, I think we're seeing greater awareness of mental health issues, and the fact that we cannot ignore mental health. It is a crisis, unfortunately, but because of this, because of our understanding and our awareness, I think that we will see a greater involvement and greater prioritization and greater mainstreaming of mental health issues in the near future in Malaysia.
Great. So I think some of the things which we have covered, quite extensively, is at the end of the day, the stigma is one of the things which we have to deal with, and I think that goes along with advocacy of mental health issues among healthcare professionals. I think regardless of whether there's COVID or not, I think stigma and how to advocate mental health, especially to our workforce and stakeholders, maybe some of the things which we have to look at in order for us to progress as a particular team together. And as exactly how Prof. Amer said, no one will ever question why you got an AMI, but somebody will actually question why do you feel depressed, which brings a lot of stigma to that. Maybe Prof. Amer, you can share how are we going to deal with stigma, and how are we going to advocate it to our stakeholders? As you said that it is actually in infancy period. I honestly feel it's still in utero. I don't think it's infancy yet. I mean, Prof. Amer, I think you're being very generous personally, but I think although there is much to do, I think we're moving in the right direction. Let's put it that way. There is now awareness. People have come to think about, even during the COVID-19 situation, we have seen that people are also looking into the mental health aspects. Not as much, but at least it was much better than what we had in the past. Maybe, Prof, you can start off this discussion.
Yeah, so I think the most, can you guys hear me? Sorry. So I think one of the ways that we can actually minimize stigma is, number one, to actually conduct these mental health awareness programs within your hospital by the respective departments that are supposed to. And if they're not there within the department, then definitely you could initiate it from the management point of view. I think that's the first thing. I think the second one is also to also participate in programs like this, where we know that before this, there were not so many seminars and webinars on mental health and mental health awareness. And now I think there's definitely a little bit more. And this is another way for us to actually, again, reduce the stigma, because as you know, the more information that you have about a certain medical condition, the more likely that you're going to be thinking about it, but it needs to be repeated oftentimes and times again. It cannot be something that happens once a year where the staff and crew change often and therefore this agenda is taken away. So, you need to have that consistency, not to say every day, but at least, within the year, at least a couple of times, so that people are thinking a lot about it. I think the third one, of course, in terms of how to reduce the stigma, is for all of us to become an ambassador to reduce that stigma, to think about mental health as being part of health, to be conscious in what you are saying and doing to other people, particularly your colleagues, because I think it goes a long way in terms of how it might affect the individual's behavior and attitudes. And I think if you do just a little bit of that, this goes a long way in actually improving mental health care among colleagues. I think what we're seeing right now is, again, the fourth one, I think, which we're already seeing is that, like I mentioned before, and I think Dato, I mentioned rightly so, that the COVID-19 pandemic has actually allowed the mental health psychosocial support system to come in place. As a result of that, we are having a little bit more awareness in terms of mental health care, but we don't want it just to be during the COVID pandemic. It needs to be there even after. Like I said, if you have colleagues that are struggling and they're able to know where to reach out, just a phone call to say that we're listening goes a long way for our colleagues. At least management appears to care. And secondly, they know that they can access service rightly without the discrimination that we hope that they don't get. And I also want to just reiterate, because some of you might have thought that, well, some of these patients, these people, these colleagues of ours, I won't even say patients, they might be one of us who are struggling with a mental health situation, really cannot function. Then they're not well, because my take on, mental health is the same as your take on physical health. If we've diagnosed them to be well and they are in recovery, they're able to achieve everything that we expect them to do. So there is no excuse if you said that you're a recovered hypertensive on treatment and you want to take a high management post with high stress, you better make sure that you know how to handle that particular hypertension. If not, probably it's not the best job for you. Similarly, if you have depression and you're in treatment and you're in recovery, you should be able to reach your full potential. If you think you can't, then more likely than not, that's probably not the best vocation for you at this point of time. Now, again, I want to also stress that if you have a major mental illness, like schizophrenia and bipolar, these are very specialized situations where a whole committee needs to decide whether you're able to practice or not. So, the most common mental health condition is going to be anxiety and depression. And this is the one that we see often time and time again. Most of you who have done masters or PhDs in terms of your study might have had problems with this. Are we saying that you are weaker than the other person? No. It's just the condition itself might have resulted, the situation itself might have resulted in you developing these particular conditions, as we would if we were, having, say, for example, hypertension after sustaining in a management position for so long without the same coping mechanisms that others would have. So I think, having this kind of thought and reflection goes a long way in actually reducing the stigma of mental health within our ecosystem.
Absolutely.
Yes,
can I add on a bit
sure,
to that? Yes. So I think yeah, I fully support what Prof. Amer has mentioned just now, and the fact that the conversation about mental health has started, certainly, and today we are talking about mental health of medical frontline workers, and employee mental health in the office or the workplace. Certainly these conversations have taken place at a greater frequency recently, and even prior to the COVID, I remember a time when almost like it was every 2 weeks once I was invited to some company or one of the major companies who would want to talk about mental health. And every time I ask them, what would you like me to say? They just say anything, talk about anything about mental health. And I started beginning to wonder really whether this is all part of that CSR compliance, just that they have to do something for mental health, or was it really a serious initiative? Nevertheless, I found a lot of employees there attending these talks, and they seemed to be very interested. And of course, when it comes to questions, it was always like, I have a relative, I have a friend, I have a neighbor who has this. It was never about I have to, sort of hide that particular to come out with it, which is a clear indication that it is still not accepted in the workplace, despite all these talks and despite all these awareness programs that we have today. And although the road ahead is much better than how it was previously, where people are showing some interest in it as well. But I think the crux of it here is there are two main issues here. One is the fact that employees today, other than those who access the services of government hospitals and government services, who are in the Klang Valley and who have to struggle with traffic jams and goodness knows what else, it is largely out-of-pocket expenditure for them to see a mental health professional. Now, they can't claim this. The companies obviously don't cover it as well. The insurance is still in its infancy when it comes to covering for mental health issues. So that is one thing. And secondly is the fact that, as I mentioned before, the companies itself must have an internal mechanism, a legal mechanism in which employees who are struggling with mental health issues are not discriminated against in any form. And for that to happen, leadership in mental health is really important. Now, the mental health professionals, WHO, psychiatric associations and all have repeatedly emphasize the link between productivity and mental health. WHO in its 2000 report mentioned something about investing for, every US $1 invested in mental health brings a return of US $4. Now, I'm not sure whether all these figures really make an impact on our corporate houses, to fully understand that. And our own former deputy says 114 billion ringgit is expected to be the loss in productivity due to mental health problems in Malaysia. So these are all big figures, but I'm not really sure how much of an impact it has. The real impact will be when you have legal protective mechanisms in place and proper insurance coverage. Thank you.
Right. Thanks, Dato. So I think many people will be wondering right now that, yes, we have talked all about mental health during COVID, mental health in general, especially for healthcare workers. Now, what do we do if we know someone who requires a mental health assessment, or even if they're having a mental health disorder or mental health issue? How do they seek help? Because I think, I think Dato and Prof can correct me if I'm wrong, the two most difficult things to do in a mental health issue is, number one, to recognize there's a mental health issue, and number two is to get help. I think after you overcome these two barriers, there are other barriers as well, I quite completely agree, but I think after you overcome these two first, I think the greatest hurdles, the rest of it, the hurdles will not seem as big as this. I mean, that is my personal opinion. I stand corrected on that. But what do we advise our healthcare professionals who would like to get mental health consultation or mental health? How do they approach the situation, and how do we offer this to our colleagues? Maybe we can start with Dato.
Well, I think as in any other case, whether we are a health professional or otherwise, the first step is often being introspective and understanding. And we are not in a position to, in some cases, we are not in a position to notice if one of our colleagues has got an issue. And we certainly know by his appearance or change of demeanor or the tardiness or irritability or whatever, that we understand that there is some form of a mental health issue. I think it's a bit tricky here. And first of all, I think if we find ourselves in a situation where we notice that a colleague has got an issue, we definitely need to talk to our superiors, the consultant, whoever it is there, who is the leader in that team, or a line manager in a corporate house, and try to say that you have a concern. And you need to gather opinions from a mental health expert for that, and not jump into conclusions that somebody has a problem. And of course, try to have a private conversation with that colleague. But the the trick is here, of course, having the conversation that begin with challenges in the workplace without jumping into issues that concerns them in private, for example, you know, something that's happening in their private life. So that is the trick here. But having said that, it must be in the context and in the background of assuring our colleague that the system will not discriminate against that colleague. If news were to leak out that that particular person needs mental health, support in any form, because nobody is going to come out and say, yes, I do have a mental health problem, you know, in the workplace, unless, of course, you're a buddy to the person and he's telling you in his personal capacity as a friend rather than as a colleague. The system must show support. That's why I keep harping on this at every forum I have, and even to the displeasure of some of the companies that invite me, and probably that's why they never invited me again. To emphasize the fact that you must have a system in place to assure them. How are you going to tell your colleague that don't worry, tell me all your problems, and we will guide you time round. When there is a promotion exercise, you will still be considered for a promotion. So that is the thing that we need to. Prof. Amer mentioned just now, EAP is getting more service that is not information, confidential information to the management of the company. Unfortunately, I must say, I think the pickup rate of this EAP services in Malaysia, I'm not sure, maybe Prof. Amer can correct me, from the statistics that I receive, I do not see a very impressive pickup rate of the EAP, because I think among our employees in Malaysia, we also are not particularly convinced of the confidentiality of this EAP. I think
I think we have lost Dato Andrew for a short while. Never mind. Before we go ahead, maybe Prof. Amer, you can share with us about, I think it is not only about stigma, but perhaps even decriminalizing mental health issues. I don't think, as far as the law is concerned, I think even in associations and even corporate situations are concerned, and even are we looking at perhaps screening annually before we pick up too late? Perhaps, one of the issues that we have these days is that we pick up mental health so late that it actually takes quite some time for them to recover. So perhaps, is that what we can do for our healthcare workers, and how do you suggest on what do we do for our colleagues?
Well, I think the first thing is going back to, what can we do for our colleagues, the advice, TALK, the let's talk. The TALK has a meaning. Tell someone that you trust your problems. A is ask for help. L is listen without judgment. And I think the last one, K, is know where to find that help. And again, it goes back to all of us to be responsible in knowing where can we find that help within our system. Now, just to give you a bit of an example, at least within my organization, if you're a staff of the university, for example, there are systems in place for you to be able to contact the staff health and also staff counseling services. And of course, for us doctors who might be privy to the Department of Psychological Medicine, you can either make an appointment to see individuals that you want, maybe discuss with them prior, or see them on this private system. Now, we've had a number of doctors that have crossed borders in the sense that you might be in hospital A, but you go and seek treatment in hospital B. But I think more importantly is that you're seeking help when you require that help. Now going back to your particular comment just now, Arvinder, in terms of, what are we doing? Should we do screening? I think it's going to be very difficult. Lots of people have mooted this in terms of screening. I think more importantly is for all of us to screen ourselves once we are aware about mental health issues. We call this being psychologically minded. And therefore, if you are psychologically minded, you're going to be more sensitive towards your mental health care. And if you're noticing that your mental health care is deteriorating or somebody's commented on it, then therefore I think that's probably the best time for you to seek help, because we know that our mental health care will fluctuate. But I think more importantly is that we know that when we are having just general stress, probably a bit of distress, there's lots of things that we can actually do to actually prevent us from having a mental illness, which we're trying to avoid. And if you're thinking about the statistics, the mental health situation might be high, and I think that's why we want to have this kind of awareness, but the mental illness rates are actually very low. And therefore, not everybody has or gets a mental illness, but people can develop mental health situations which are, number one, preventable, and number two, more or less curable if we're able to detect early, but we need to be aware that it is an issue. And again, I'll give you a simple example with regards to hypertension and cholesterol. Having high cholesterol is probably not that great, but it's something that we can actually prevent, particularly if we are aware about our cholesterol, about our family history, for example. Similarly with hypertension, you probably check your BP once in a while because you're cognizantly aware about it. But once it persistently is high, once the cholesterol is high despite everything that you actually do, then that's normally when we come forward to seek our friends and ask whether we're really having hypertension or hypercholesterolemia. And again, once our colleague has actually done the necessary assessments, then some kind of plan will come on place. The difference, I think, is that most of us will know where to find that help if we need to with regards to hypertension, but most of us might not be aware of the services that are available within our organizations and hospitals if we're struggling with some mental health issue. I just wanted to also share with you some of my mental health colleagues that are out there. Number one, if you're familiar, you've got welfare group that often have counseling services that you can actually seek. For hospitals that might have a clinical psychologist, this is another group of people that you might want to seek if you need some help in regards to mental health. You've also, for those in the nursing staff or from the lower support staff, you might know a friend who is a psychiatric nurse. And again, they can provide some level of help as well. And of course, at the top of the food chain is going to be the psychiatrists. But even a little bit below them, that does a lot of work on mental health, and some of them have special interests, will be our general practitioners or our family medical specialists, who can also at least assist in finding the right services needs.
Thanks, Prof. Prof, very interesting. You say that certain doctors would like to see certain people get their mental health assessment and even to have help. Do you think that special teams should be formed within the psychiatry department to look at the well-being of healthcare professionals' mental health, and maybe should they also move along with screening, or maybe getting a brief screening on a yearly basis? Is that something which you think will actually help with the situation, Prof?
Well, I think this has been rooted even when I was a trainee at that point, Professor Brian Ho from UPM, for example, and I think Professor Azhar also from UPM. And again, we are seeing a little bit more of that support needed now, particularly during the COVID pandemic period. But we've not been very very autocratic in who we assign to assist colleagues, because now people have the opportunity to choose the service and the help that they need. Now, I know where you're coming from, Arvinder, in terms of trying to put a screening tool, but we don't want to unnecessarily catch people who might just be having life's normal worries. I think what we're trying to what we're trying to mitigate is those who are at high risk of developing a mental illness, to prevent them from getting a mental illness as a result of the mental health situation that they might be in at that point of time. And that's why I'm not such a big advocate for general screening. However, I am an advocate for as being part of health, and therefore when they are psychologically minded about their health in generally, then therefore, once they realize that there's a dip, persistent dip over time, despite their best efforts in actually mitigating or responding to these particular dips, then therefore these individuals will be able to come forward. And more importantly nowadays, my advocacy is more towards, like I mentioned at the very beginning, if you needed that help or your friend and family needed that help, do you know who to call? Do you know which group of medical doctors would you like to visit? You know, and I think it should be as automatic as if we had somebody who just collapsed in the middle of the street, you know, where you would know what to do, rather than you asking people, hey, who should I call, or where you're at the moment.
Just a quick question. I have a lot of people who privately ask me, you know, that, you know, like how Dato had mentioned prior to this, that, you know, they always say that a friend has a problem, is never particularly pertinent to them. I always share with my colleagues and friends who may have an issue. I always tell them, to put it nicely, they may want to take the DAS scale just to have a quick screening to see whether there are any issues. We had arguments about some of other colleagues who actually prefer PHQ-9. But Prof, just very quickly on if let's say it was to be introduced in the PESO screen, like exactly like what you said, you know, a yearly sort of thing, just to know whether it's deteriorating or not. Which scale would you recommend for them to be something which is quite quick and also not mind-boggling? As we can see, I think the DAS scale has been introduced in the Klinik Kesehatans, and even there's a Malay version, which is I'm very thankful for. But which one do you think is perhaps one of the easier and better tools for our colleagues, not only for us to use, but also to pass to our patients and maybe other colleagues who have issues, who are having mental health issues?
So, you know, you rightly mentioned the one that's popular is the DAS-21, which is currently being used in Klinik Kesehatan mainly, and some of the studies that we've done also have been using the DAS-21 just because of its familiarity. It looks at depression, anxiety, and stress. Now, the other one that's been used in the NMHS study looking at mental health is the General Health Questionnaire, the GHQ.
GHQ, yeah.
It also looks at some level of stress, a bit of depression, and other well-being questions. The PHQ-9 specifically only looks at depression. So you've got the PHQ-9, and then you've got a shorter version, I think the PHQ-2 and the PHQ-4 as well, but they're mainly looking at depression. Now, although granted that the most common mental illness in Malaysia is depression, followed by probably anxiety, and third, probably running very closely is going to be substance use. But it doesn't, it can be a diagnostic, it's very, it has a strong diagnostic component in terms of the PHQ, particularly for depression. Now, I think the DAS-21 is useful for most of us is because it allows you to have a signal that this individual is in distress, but it doesn't necessarily mean that that person has a diagnosis. And I think this is important when you're screening or you're doing, you know, advising or advocacy, because you can do the DAS many times and see whether these scores are improving or not, depending on whether you've put your own intervention or not. Yeah? I'll give you an example. If you realize that your stress levels are high and you're realizing that it's because you are a frontliner in COVID, and you're worried about some symptoms that friends have mentioned, you're a bit more irritable, you know, you appear like you've been a bit more disheveled. So you do a DAS-21 on yourself and you realize your stress level is high. You know, you talk to your friendly psychologist maybe in your hospital, they give you some skills in order for you to cope. You do these skills over the next couple of weeks, you come back and do the DAS and you see the score has reduced. That means that whatever intervention that you've put in your place, yeah, whether it is to you know, sleep a little bit better, exercise after you come back to work, do some meditation or mindfulness maybe, or reflections, and you've noticed that your scores have reduced, it just means that you know, we have detected that you were struggling with some level of mental distress, not a diagnosis. You've put intervention in place, which are cheap, you know, available out there. You can do it yourself. and then you realize that the scores have actually reduced, therefore it's actually worked. Similarly, if you are struggling through some level of trauma, and you notice that your maybe your depression skills increase, you meet somebody and they give you some advice. You've tried that, and you do this skill again, maybe say a few weeks later, a couple of weeks later, and you notice that the scores are persistently low. And you seek your friend again and with more time, and you do it the third time and you see it's low, then more likely than not, it's something that is not being able to be addressed with psychosocial support. You probably want to see maybe a psychiatrist at that point of time, or a clinical psychologist who will be then re-evaluating you and seeing whether you really or might not have depression, which needs further intervention than just giving the simple advice that we often give for people. So that's how I look at the DAS being used. What's being happened right now is there's a misuse of DAS, where the moment it's high, people assume that they've got something.
Depression. Yep, correct.
High anxiety, oh, I've got an anxiety disorder.
Yes.
High depressive scores, I've got depression. It's not meant to be like that. It's just a screening instrument. It allows you to have a signal that things are not doing really well. And therefore, if it's persistently at that score, then you probably want to come forward to see somebody.
I completely agree with you, Prof. Sorry, just to share. I completely agree with you, because there are times where I get a lot of patients and even a lot of people who answer the DAS scale, and when they go off the scale, they actually said, hey, you know what, I'm having a issue. But I always tell them it's just a screening tool for you to actually go and see a professional, get professional help to actually find that there's an issue. Sorry to interrupt you, Prof, but I just wanted to ask you, there are some people who go for interventions and then they have to retake the DAS to see whether they're improving. Sorry, I just wanted to ask you, what is the time frame we are looking at between the first and the second assessment between the intervention? Something meaningful. Normally, like certain things like the Glasgow Coma Scale, for example, it is quite dynamic over a short period of time, depending on what you have given them. What is the dynamicity of DAS scale, and how long should they be taken apart? Just for some of our colleagues here.
I think it depends on when we, how long has this person been complaining about the issue, and how severe is the issue in terms of their functioning, normally, as I was just going to say just now, if you're going to see a general practitioner, often these people are struggling with problems that might been there for a few months. So the DAS scale done, say 2 months after they've reported these symptoms, confirms that they are really struggling with something, and my friends, the general practitioner, will then be able to refer with some confidence that this person has been struggling with symptoms for 2 months. The DAS score appears to be very high for depression. This guy needs to seek help. What I'm talking about in terms of the DAS score that we want to use it is as a way for us to screen ourselves if we're psychologically minded. We're struggling with an issue for maybe a couple of weeks. We do the DAS score and it's confirmed that our stress levels are high. We see a friend or we read a little bit about what to do for stress. We might want to repeat it a month later, because it's only 2 weeks since when we first did the DAS score. If the DAS score has improved over the next month, good and fine. If for some reason it's starting to deteriorate, and what we'll notice is that we'll notice the stress levels to still be high, but maybe one of the other components will also start to increase because we're struggling. And this is now in total time, it's already 6 weeks. So at that point of time, we might want to do it maybe another 2 weeks, because if we're not improving within the next 2 weeks, it's been 2 months since we first complained about that problem ourselves. And therefore, it'll be exactly like the person who came to the GP 2 months later, who did until it's really bad that somebody do the DAS scale and then refer them off. So, often we talk about between 2 weeks to 4 weeks before one does the DAS scale. Again, it's a screening instrument. So for some of you, you don't have to be worried about that. There's just 21 questions. If you're feeling that you're struggling, you might want to do it. If you're seeing that there's some parts of your mental health that is not very positive, like I said, these are learnable skills, preventable things that you can actually do. I do them myself as well to see whether I'm coping or not coping. And if I'm struggling, then definitely I'll be looking for more opportunities to manage whatever I'm struggling with before I actually seek some level of intervention from colleagues.
Awesome, Prof. I think, thank you so much. I think Dato having some problems coming on, but it's okay. Thank you so much, Prof. I think it was very beautiful and insightful session. And I think before we go on to the questions, there are some places or some societies and NGOs who actually offer help to our colleagues. I think public in general, and even our healthcare workers who need to seek mental health if they want to talk to someone and if they're a bit shy to come forward. These are some of the helplines, some of the websites who you can actually contact. There are some like Befrienders, they have local areas, and they have the central areas, and these are free support groups that actually help. Maybe some of our colleagues who have joined in today can actually take note of this if they know a colleague, or if they themselves would like to get help, or even if they have patients who want to have some amount of counseling. I know a lot of them like to call NGOs like Befrienders because they feel that it's over the phone, there is no face-to-face contact. Perhaps they feel a bit more comfortable, they put at ease, and they can actually share their issues. So these are some of the websites which and some of the emails which you can actually gain help from. Are there any questions from the floor? Everybody has been quite silent. Everybody has been muted. You have heard my voice. You have heard Prof. Amer's voice. You have heard Dato's voice. But we would like to hear from you as well. Anybody has any questions? I don't see anything. Maybe you can put it in the chat group, or you can unmute yourself and just on your cam if you're decently dressed, and share with us what's going on in your mind pertaining this topic. Or perhaps while waiting for this question, Prof, can you just share with us what have you been seeing in your practice on healthcare professionals coming in during this COVID-19 pandemic? What are the common issues that are being seen in the form of mental health issues, perhaps which some of our colleagues out there can actually look out for? Because there's a whole range of things that can that can occur to anyone. But what are the common things which you are seeing, Prof, in your practice?
So the reported mental health issues that have been brought up time and time again, particularly over the last 6 months, number one has been anxiety disorders. And they could range from general anxiety disorder to panic disorders, and also post-traumatic stress disorder. The last one being because there is a perceived trauma for some frontliners, particularly at the early stages when they felt they were ill-equipped with regards to their protective gear, for example, and the risk was at that point real, and there was lots of lack of information about the disease. The second one has been progressive burnt out, leading to depression. This has been something that we've seen time and time again. So these are the two main issues that have been coming forward in terms of mental health needs of our friends, particularly during this particular COVID period. As I mentioned, even though I'm an addiction psychiatrist, we don't often see, although the literature states so, that we medical doctors are also at risk of developing substance use disorder. At least in my practice, I've not met too many of us needing that kind of assistance. Even the time when I was trained under Prof. Hussein as well, I don't remember seeing too many. Yes, there were some colleagues that came forward, but I think most of us still were able to manage, unless we probably had some issue before, like when we were medical students, or and therefore you probably never reach very far because your addiction would have stopped you along the way because of whatever reason or another. So these are some of the issues that we've seen over the last few months during this COVID period.
Yeah, very interesting. Any questions from the floor? We're running slightly out of time. I think we all were so passionate in it that we were, giving as much of feedback as we want. We also like the feedback from our crowd. Are there any more questions? We're slightly running behind time by about 20 minutes.
I
We
think
apologize.
I think they're tired there.
Yeah, I think so as well. I think some of them have also joined in from hospitals. I've seen, I saw a hospital there where I think they're having a couple of people and they are saving bandwidth as well, which is a very brilliant thing to do. Sorry?
I think what we can do, is that, you know, if there's no questions, again, we're more than happy to take these questions. And I think we've lost Andrew Mohanraj due to probably connectivity issues. I mean, he is in Nauru. Questions, by all means, you might want to email them to Carmila.
Yep.
And what we can do is we can take those questions and answer them and hopefully put it up on maybe my seminars or something, so that you know, people will be able to look at those questions and also be answered.
Yes, awesome. I think that would be a brilliant idea. Yes.
Because I just wanted to share with you that Dato's input is actually quite useful, because he practices in many countries before. He was with, I think, the World Health Organization, and is very active in the World Psychiatric Association as well. And currently now doing some relief work, I suspect, in Nauru. So he comes in with the perspective of the systems. Myself, coming from the university, we're coming from a local perspective. And of course, with my advocacy work, we're having lots of input from the people who are struggling with the mental illness, whether it is a medical profession or not. And therefore, I give a different dimension in terms of the discussion. So I think if you've got questions with regards to any of these issues, particularly pertaining to the system or local infra that we can push forward, then therefore, by all means, maybe want to email to Carmila, because her email address is the most famous now. And therefore, you know, she'll probably pass the questions to Arvinder, and then, you know, myself and Dato Andrew will try to answer them and get those answers back.
Awesome stuff. Absolutely spot on. So if there are no questions, I think the email for Carmila, she has already put it in the chat group, is carmila@myseminars.com.my. So if there are no other questions, I would like to thank, on behalf of My Seminars, I would like to thank Prof. Amer and Dato Andrew for your precious time in you know, sharing with us a lot of things, and really appreciative. Thank you so much, Prof. Thank you so much, Dato. And hope everyone had a good time, good session, and see you all again. Thank you.
Thank you.